This is part 3 of chapter 9. In this part, we're going to be discussing explicitly healthcare, the United States healthcare system, as well as introducing some of the systems of comparison countries around the world. So, oftentimes people think that there is an innate relationship between how healthy a country is as well as how much money they're spending on healthcare, how much resources they're investing in healthcare. But just because we assume that there is this relationship between how healthy a country is and how much money they spend on healthcare expenditures doesn't mean that that relationship is in fact true. So the big question here is, how much does healthcare really matter? In order to answer that question, we first need to take a step back and make sure that we all are on the same page when we are thinking about what is healthcare. Healthcare is really any activity that's intended to improve health. That may not be the definition that you were expecting. You were probably expecting more the definition that is for medicine, the institutionalized system for the scientific diagnosis, treatment, and prevention of illness. And that's because oftentimes in America, when we hear the term healthcare, that's what we think about. We think about doctors and doctors' offices. We think about hospitals and we think about surgeries. We think about prescriptions and medicines. We don't necessarily think about, vitamins or, yoga instructors or meditation or just walking around outside. But because all of those things are good for your health, all of those things are in fact healthcare. But just because of how healthcare is oftentimes thought of in kind of common uh, conversation and how the average person thinks about it in their mind. When we talk about healthcare in the United States, know that most of what we are referring to is in fact medicine. It's the data that we get from our practitioners and our physicians and our hospitals. And of course, when we're talking about health insurance, it is oftentimes so people can access and afford medicine, not necessarily that broader definition of healthcare. So now that we have those definitions out of the way, let's return to that question. What is the relationship between the amount of money a society spends on healthcare and their overall health? Well, if you look at how much a country spends on healthcare, United States spends more than any other developed country. When you look at what percentage of our GDP, our gross domestic product, is related to national health spending, at 16.6%. This was like in 2015, which is a good deal more than pretty much all of our other fully industrialized nation comparisons. So if we spend that much more, then we must be healthier, right? Well, let's consider if that is in fact the case. Let's look at a little bit of empirical data. Let's start with life expectancy. We spend all that money, so we clearly must be outliving other countries. Well, the answer to that is, although life expectancy in America has gone up for men and women, although women do outlive men, that life expectancy still is less than the life expectancy that you see in other countries. And if you're even looking at the top 10 countries in life expectancy, and this was like right 2009, 2010, you'll see that we're behind countries like Japan, Singapore, Hong Kong, Australia, Canada, France. And that actually, at least at that time, we were ranked 50th in the world. So far from top 10 in terms of life expectancy. What about something like infant mortality rate? So in video 1, I discussed IMR. Infant mortality rate is when a child is born and they die before the age of 1. And in America, for us to be a fully industrialized nation that spends so much money on healthcare, you wouldn't expect that we would have a high IMR, but we do. And as recently as 1990, I mean, our IMR was strikingly high. So much so, President Bill Clinton at that time declared it a bit of a health care emergency, and they put some resources to addressing the problem. But even as it has declined to around 6%, 7%, you'll see that we are still significantly higher than countries like Sweden and Japan and Finland, where it's 2.5, 2.6, 2.7. So, what is underlying that? It definitely probably has to do with access to prenatal care, and access to healthcare in general. It has a lot to do with, of course, our healthy behaviors, high rates of addiction and alcoholism and smoking. But it also has to do with, the other types of deficiencies in our social safety network. There is no paid maternity leave at the federal level. So it depends on what state you live in and your job, whether you get paid maternity leave and whether that means you have to rush back to work or not. And there certainly is no paid paternity leave at the federal level if there's no paid maternity leave. So all of those things, of course, kind of factor into that high infant mortality rate. And so, if you're looking at life expectancy, if you're looking at infant mortality rate, there are other kind of data indicators that also suggest America is not as healthy as some of our other nations, our other fully industrialized nations, like, our obesity levels, our issues with addictions, addictive substances. Our suicide rates are higher than some countries. All of that suggests that despite spending a lot of money, our healthcare system, our system for delivering our healthcare to our citizens, is not as good as it should be. So before we talk about the problems in the American healthcare system, let's think about what the basic objectives of that system should be. There are three basic objectives that you should have in a healthcare system. One is access. You want people to be able to access doctors and hospitals. Two, cost containment. But you don't want people frivolously accessing hospitals, doctors, operations, because you want to be able to contain your costs. There has to be some type of limit on costs, so there is not just an explosion of cost in providing care. But then you don't want to cut cost by diminishing quality. So you want to provide good quality care to people. And so we call this the healthcare triangle. That if all three are doing well and they're perfectly balanced, then you have a fully functioning healthcare system. However, if you have a change in one, it is going to change the other three. And so in the case of U.S. healthcare, it has been described as being costly, inequitable, and ineffective. So it speaks to cost, access, and quality. So what do we do? This has been the question that has existed for at least the last two and a half decades. And part of why we've had this focus on the healthcare system in this last 25 years or so is because, as I've kind of stated, the United States ranks lower than most other high-income countries in the health of our population. Yet we spend more per person than any other country. And that our health or lack thereof can be contributes to economic inequality, as well as reflects the economic inequality that exists here. Just meaning that living in a country with wide amounts of income inequality, wealth inequality, has certainly factored into the inequalities that we see in health. But then those inequalities in health also then factor into ongoing inequalities that exist in life chances between the rich and the poor. So we'll talk about these problems individually, and we'll start with cost. So we aren't doing cost containment well. There's a cost problem. Healthcare costs were more than $3 trillion in 2016, and this is compared to when they were $12 billion in 1950. And obviously, our population has grown, and the share of elderly people in our population has grown. And we talked about in part one how that can impact costs. But still, this is just a dramatic increase in cost over time. And that's what that graph is showing, that especially for private insurance, that there has just been a increase in millions of dollars that we are spending, trillions of dollars that we are spending. So your book talks about 6 reasons behind the soaring costs. Number one is the spread of private insurance, which then factors into how much procedures and cost and the kind of compensation rates of physicians. There are more doctors who specialize, and specialists cost more money. More high technology. It's needed, but they oftentimes roll those costs back onto patients in terms of how much they then charge for procedures. A lack of preventative care. So we focus more on downstream solutions to our health and less on upstream solutions in America. Although upstream solutions focusing on preventative care not only makes good sense, but is oftentimes less costly. As mentioned previously, we have an aging population, and because of where we are in our epidemiological transition, our citizens live for longer, but are not necessarily healthier. They have degenerative and chronic diseases, which they don't die from, but they can be costly to treat and manage. And then we are a lawsuit happy country. And so that also contributes to the costs as physicians seek to protect themselves. They carry a lot of insurance. That's costly. And once again, they factor those costs in terms of what they then charge for their services. But it's not just a crisis in terms of costs. We also have issues in regard to access. And so if we're going to talk about the access crisis, then we almost need to split it in kind of 2 time periods: pre-ACA, Affordable Care Act, and post-ACA, Affordable Care Act. So there are several ways that people accessed and paid for healthcare pre-ACA. What was most common for a long period of time was fee for service, direct fee. Doctors would just charge a straight fee. You'd have to pay it out of pocket, or you'd be charged for it later out of pocket. But this was the way that things were done for a very long time. Of course, the problem became if a person could not pay but desperately needed a procedure or surgery, what did that mean for the doctor? And there were a lot of doctors, especially in small towns and rural areas, that were, barely staying in business because they were providing service, but they weren't getting paid. And kind of to address that problem, there arose the third-party fee for service, what we call private insurance, where people pay a third party a fee in order to access doctors at a kind of a reduced rate. And the first of the health insurance companies were Blue Cross Blue Shield, which of course are now together, but at the time they originally started, they were separate. Blue Cross was insurance specifically for hospitals, and it came first. And then Blue Shield came later, and it was insurance for health practitioners, physicians, office visits. And so, how much There's all types of underlying math that goes into how insurance works, community ratings, right? So how much the doctor charges for your premiums or deductibles. It has to do sometimes with the overall health of your community. Actuarial risk rating. So those of us that are considered high risk versus low risk might pay differing amounts to our insurance company in the form of our fees. Two different forms of insurance companies kind of developed HMOs, health maintenance organizations versus PPOs, preferred provider organizations. HMOs are ones that provide medical care for a fixed fee. Usually this is very managed care where you have to go through your primary care physician and you're assigned one of those, and they kind of determine whether or not you get to see specialists, whether or not you can get certain forms of care. HMOs are very popular for controlling cost. However, it eliminates a lot of choice and flexibility to the patients. PPOs, preferred provider organizations, are much more flexible in the fact that if you are part of a PPO, you can go to any provider that's in your network. The problem with that, though, is that it is not nearly as good as cost containment. And especially when you start talking about specialists, this is where we have seen some of those exploding costs. There are all types of problems that people have with their private insurance, whether HMO or PPO. But despite these problems, this is how most people are covered. 67.5% of people are covered by traditional insurance. Most people receive it through their employer. That's who their community rating is based upon. But post ACA, people also now can buy it on their own, have to buy it on their own. Before ACA, that was an option for people, but it was oftentimes a very expensive option that people did not always opt in to do. The other way that people can access it is through government insurance programs. And there are two primary government insurance programs, Medicare and Medicaid. Medicare is for people that are 65 and older. Medicare has also been expanded to include people who are disabled or people who of any age, as well as people that have like kidney failure or long-term kidney disease. Medicaid is for people that meet specific income restrictions, so poor people, that then also meet one of the following criteria. They are pregnant women, children under the age of 19, people who are over 65, people who are blind, people who are disabled, people who need nursing home care. And so if you notice that there was a little bit of overlap, there is. So if you are poor, you meet the income restrictions and you are older, over the age of 65, or you're disabled, then you are what we call dual eligible, and those people can pull from both programs. The final type of government insurance is the care that veterans receive through the VA, the Veterans Administration, their government operated hospitals and healthcare facilities. So when we're thinking about, who receives Medicare and Medicaid and the cost associated with Medicare and Medicaid, it's worth noting that almost half of Medicaid recipients in this country are children. But although they are almost half of the recipients, when we look at who costs the most under Medicaid, it's not children, because generally children are fairly healthy. It is largely the blind and disabled, and then the kind of second largest is the elderly. And both of these programs, and this is old money, this is from like 2010, cost a lot of money, 37 million, and they cover a lot of people. Um, I emphasize this because part of the issue is especially with Medicaid, when there are debates on whether we cut it, it raises the question of how are these people going to get their health insurance covered. Um, all of these are people that are largely unable to work, either because they are retired or they're disabled or they're children. Um, and there is no easy answer for that. For Medicare, part of what's contributed to that cost, of course, is the fact that people are living longer. When that original age of 65 was set, the expectation was that people would live maybe 10 more years at the most. Now, of course, on average, people live 15 years or more from that point. I mean, some live, of course, much longer. And so if you didn't have private insurance because your employer didn't provide it and you didn't want to pay out of pocket, and you weren't elderly or disabled, and you did not meet the income restrictions as well as the other criteria to be on Medicaid, pre-ACA, we had a real issue in this country with people then just not having insurance at all. Um, Right now, post ACA, that percentage is 9%. Pre ACA, this was 17, 18%. So it was reaching almost, 1/5 of the population. And this would be especially problematic because no one plans, of course, to get a serious illness or an accident. And when they would have a serious illness or accident, it is not like they would not receive care. They would receive care in through ERs, which could not turn people away. But then, of course, their bill would be astronomical, and without insurance, they would have no hope of paying. And so oftentimes the hospitals were left with these ridiculously kind of high bills of people who had not paid. And they in turn would roll that over to the government, who would then have to pay a portion of that back to the hospitals. And so I always like to emphasize to people, that taxpayers were paying for uninsured people in a roundabout fashion even before the ACA happened. So who are these? Who are the uninsured, and why aren't they insured? Well, statistically, we know that they're a mix of people. It's people who don't feel like insurance is affordable, people who had insurance through their job, but then they lost their insurance. And so they lost their job and therefore lost their insurance. There are some people that feel like, that they have just no need of it. Young people in particular, when they aged out of their parent system, and this was pre-ACA, so, they would age out, or they would leave school, which was the other way that people could oftentimes get health insurance, is through their colleges. If they were college students at bigger universities, they would be without insurance. And it was a mix of racial groups. It was a mix of people who were both undocumented non-citizens to people who were eligible for government programs, but for whatever reason just did not enroll. Some people earned, money, but they were self-employed and did not necessarily want to spend money on health insurance. So a variety of reasons kind of contributed to America having a high rate of people that were uninsured pre-ACA. And this was just problematic for a variety of reasons. People who don't have health insurance don't receive preventative care, which means that it was contributing to years of life lost or early death. People who don't have health insurance were less likely to get like prenatal care. So this was certainly contributing to our high infant mortality rates. So regardless of how very political health coverage is and has always been, something had to be done. And so during that debate about what was to be done, um, and this debate continues today as we are going into an election year, and people argue that we need Medicare for all. It's just worth noting that, what Medicare for all would be universal coverage, that everyone in America would receive health care through the government. And it's called a single payer system, because the government would be the entity paying the bills, paying the cost of healthcare, to the providers, to the hospitals. And how people feel about this varies. Certainly people that are pre-universal coverage, not pre, but pro-universal coverage, pro-single payer system, they oftentimes argue that people have a right to healthcare. People that are not pro universal coverage, there's talk around, socialism and governmental overreach. Some people argue, that it can become a moral hazard, in the sense of it opens kind of the floodgates for people to abuse the system. And so that's why at the time the Affordable Care Act was passed in 2010, although there was some discussion about it being a single payer system, that conversation didn't get very far. Instead, what it wound up being was a mandate. Two mandates in particular: individual mandate, where people had to acquire health insurance or face a penalty, and an employer mandate, where if your company was of a certain size, you had to offer it. And then there was also a component that was later struck down and made optional. So certain states adopted it and certain states did not, where Medicaid was expanded. So before we get into some of the specifics about the ACA, it's just worth noting that although the ACA has not been necessarily popular, although it has grown in popularity with every passing year. But despite that lack of popularity, a lot of people don't want to return to the old system either, because it also did not work. But the goal of the ACA was that it was meant to gradually bring about changes in how healthcare was delivered and funded. And it did this by requiring all families to now pay an insurance tax. It did away with pre-existing condition clauses by insurance companies, which made people that had pre-existing conditions, it made it very difficult for them to get health care, and for that health, or to get health insurance, and for that health insurance to not be super costly. It increased the age limit on how long parents could include children on their insurance plans. It went up to age 26. Before, some insurances, it ranged from 18 to 22. Like I said, pre-existing health issues could no longer be used as a reason to deny people coverage. That individual mandate, everyone had to purchase, and then if you did not, you were subject to penalties. And so, although this varied state by state, because states were allowed to set up kind of their own, health insurance networks, most of the plans had 4 levels: bronze, silver, gold, and platinum. And they varied by how much they cost, as well as kind of their deductible, and what it covered. Although the ACA did make some things mandatory for insurance companies to cover. So for instance, for women, a lot of our like women's wellness, annual exams, and at that point they had to be covered fully, which before, depending on your insurance, that maybe was or was not the case. The part that got struck down and therefore was only adopted by states on an individual case by case was the Medicaid expansion. Like I explained with Medicaid, you had to, before, Medicaid was meant to cover people that were low income, but that had other criteria, right? They were pregnant, they were a child, they were elderly, they were disabled. The Medicaid expansion was meant to cover people who were low income but did not necessarily fit one of those specific low income groups. So in this case, you could be a single guy, you could be the adults in the family instead of just the children. So this was meant for people that were going to financially struggle to buy their own insurance on the marketplace. This was meant to cover them. States, some states picked this up right away, did the Medicaid expansion. A lot of conservative states initially did not. Since then, some states have gone back and have reconsidered and have expanded Medicaid as a way of making sure that the low-income adults in their state were not going to be left out without any available medical insurance and care. So the ACA is still problematic and not ideal. It's costly. There's still coverage issues. Certainly pharmaceuticals they weren't addressed at all, which for people that have to buy things like EpiPens or insulin, all of those things are costs. So it does raise the question: is there a better way? And to answer that question, oftentimes what people do is they look at what other countries do. So your book goes over several countries and their systems. I kind of put the most important takeaways from China, from Russia, from Sweden, from Great Britain, Canada, and Japan, all on the slide. Please read those pages carefully in your book. For the sake of keeping my videos somewhat reasonable in length, I'm not going to go over it because I would largely just be restating what is written there. So instead, I'm just going to encourage you to turn to those pages. And that is it for chapter 9, part 3. There will be one final part of the video series that comes after this, where I'll be talking about theories and policies solutions.